And today is the first webinar from this module, which will be delivered by Dr. Sai Sunil Kishor from Visakhapatnam. And the webinar is about neonatal sepsis. So without wasting any more time, I would like to invite Dr. Sai Sunil Kishor. He is the consultant neonatologist at Medicover Hospital, Visakhapatnam, Andhra Pradesh. Sir, I would like you to take over.
Yeah, thank you very much for that kind introduction, and I thank UNICEF for giving me this wonderful opportunity to interact with all SNCU staff as well as doctors. So in this session, we are going to discuss regarding sepsis. So this is the first talk of module 5. Let me share my screen.
Yes, sir, we can see the slides now.
Yeah, you're able to see the screen, no? No.
Yes, sir.
And my audio is fine?
Yes, sir. The audio is also fine.
Good. Okay. Thank you very much for the opportunity, and let's go ahead without wasting much time. So this is the first talk in module 5 regarding sepsis in preterm as well as term newborn care. So what I'm going to discuss in today's session is how to evaluate a case of sepsis, and how to rationalize antibiotic use, and how to prevent. And many times actually we think of sepsis. So when to think beyond sepsis. So because most of the times actually we think actually it is sepsis, but baby won't respond to our antibiotics, and after 3 to 4 days, like by the time we start thinking of sepsis, we may lose the baby and we may lose the boat. So what I'm going to discuss is these are the 3-4 aspects of sepsis today. And what I tried to do is, like, rather than a monotonous talk, so I tried to incorporate some of the case scenarios. And as we go through the case scenarios, we'll learn like regarding various aspects of sepsis, and we'll give take-home messages at the end of each aspect. So now, first coming to the evaluation of sepsis, how to evaluate a case of sepsis. So in this, what are important is like how to stratify them, how to stratify the babies based on the risk for sepsis. Especially this is pertaining to the early onset sepsis, so which occurs in the first 48 hours of life. So and second aspect will be on septic screen and some of the newer diagnostic markers. So what is early onset sepsis? So any sepsis which is occurring due to the perinatal risk factors, perinatally acquired sepsis is called early onset sepsis. So by definition, it is till 72 hours. So if it occurs within first 72 hours of life, then you call it as early onset sepsis. So beyond that, it will be late onset sepsis. And there is a term called even very early onset sepsis also, like if it occurs within first 24 hours. So now let's take this particular case scenario and we'll discuss various aspects of early onset sepsis. We have a 34-week baby born to gravido-3 mother and spontaneous onset of labor, born by vaginal delivery, and mother had urinary tract infection and she was on treatment, and mother also had PTPRYM, preterm premature rupture of membranes, for 22 hours. So this baby after birth actually had developed respiratory distress. It's 2 hours of life, and we have started this baby on CPAP. So last month we had beautiful discussion on respiratory distress as well as the supportive care, CPAP, and initiation of ventilation. So now here, like, is it early onset sepsis, and what are the differential diagnoses here? So here actually the RDS is one of the strong differential diagnoses, isn't it? So hyaline membrane disease is one of the strong differential diagnoses. But definitely, like, this particular case had multiple risk factors also. So you need to consider early onset sepsis as well as congenital pneumonia also as a differential diagnosis for respiratory distress, apart from many other causes like your surgical causes as well as other causes. So these two are the like most common differential diagnosis at this point of time. So now how to stratify this baby and how to score this baby based on the maternal risk factors and symptoms. Why we need to do this? So this is because to take decision on starting antibiotics, whether to start a baby on antibiotics or whether we can just monitor this baby and without starting antibiotics. So that is the basic idea. So actually across India as well as across the globe, there are many stratification scores. So in India, like this is one of the early score which was devised from PGI Chandigarh itself. So which shows that actually like the score is given to different parameters. Like you have based on the risk factors. So if mother undergoes intrapartum vaginal examination more than 3 times, then it is given a score of 6. Clinical choreamnionitis again 6. Birth weight less than 1.5 kg, some score. So the purpose of this score is like whatever the factors are there, you give a final score. So if the score is 0 to 6, then we need not start antibiotics and we can monitor and observe the baby carefully. If it is more than or equal to 7, we have to start empirical antibiotics. So that is the idea. So if the score is 0 to 6 means like the chance of having early onset sepsis is less and you can wait and watch that particular baby. Similarly, like there's one more report which is published in American Academy of Pediatrics. So basically again the purpose is same. So this is for babies who are less than 34 weeks. So if there is any maternal cervical incompetence, PROM, spontaneous preterm onset of labor, non-assuring fetal heart. So these are all the babies who are at risk of early onset sepsis. So in a baby who is symptomatic, like baby is having respiratory distress and with risk factors of sepsis, then you need to start antibiotics and of course you will send blood culture. And if the baby is fine by 36 to 48 hours, and if your workup is negative, sepsis workup is negative, then you can stop the antibiotics. So you will consider antibiotics in a symptomatic baby with risk factors. Once the baby is fine and the septic screen is negative, then you will start, your sepsis parameters are negative, you will stop antibiotics at the earliest possible. So as you can understand, actually here, the even spontaneous preterm onset of labor is also one of the risk factors. So because the most common cause for spontaneous onset of preterm labor is again subclinical choreamnionitis or occult choreamnionitis. So this is also one of the risk factors for early onset sepsis. So why we need to do all this exercise? What is the purpose of this stratification, giving scores and these things? So basically to avoid overuse of antibiotics and not to miss a baby with sepsis. So we don't want to overuse, and at the same time we should not miss a baby with sepsis because it can cost a life. So is it in this particular case what we have given, so what will be the decisions? Like we need to start antibiotics and we need to send cultures, and this particular baby has multiple risk factors. Like as you can see, this there is spontaneous preterm onset of labor at 30 weeks, and mother had urinary tract infections, and there was rupture of membranes duration of almost 22 hours, and baby is symptomatic baby. So because of all these things, definitely here there is no question of not starting antibiotic. You need to start antibiotic and you need to send the culture. So this is one scenario. So if the baby is symptomatic and risk factors, so you need to start in a baby who is having only risk factors and asymptomatic. So in those babies, depending on the scores, so you can probably wait in those babies. Okay, now let's discuss another case scenario. So this is the first case scenario which we discussed. Now let's discuss so another case scenario. This is a 31-weeker, 1.1 kilo. Baby is born by emergency LSAs for antepartum hemorrhage and otherwise well for first 3 days and on increasing feeds. So baby is in SNCU. And at the end of day 3 and day 4, baby developed mild abdominal distension and there were pre-feed aspirates. So what are the important aspects in this case? There are no perinatal risk factors. The emergency C-section was done for maternal indication. And baby is IUGR, like baby is having weight of 1.1 kg. And we started feeds at the end of day 1 or day 2, and on increasing feeds, now baby developed some pre-feed aspirates and abdominal distension, which occurs quite commonly in SNCUs, isn't it? With such kind of small babies. So now, what are the differential diagnosis, whether it's a sepsis or whether it is something else? And in such scenarios, is there any role of septic screen? And what are the components of septic screen? So these are the three issues which we are going to discuss now. So otherwise, well baby without perinatal risk factors on day 4 develops some mild symptoms. So here in this case, like what can be the differential diagnosis? It can be simply due to gut immaturity, isn't it? So 1.1 kilo preterm. So because of just gut immaturity itself, baby can have those mild symptoms. Or it can be secondary to mesenteric ischemia. It can be early sign of necrotizing enterocolitis, isn't it? So this is a IUGR baby. And third possibility, of course, is sepsis. So sepsis, like in the, it can be early sepsis. So you have a dilemma, like in this scenario. So whether it is in a well baby, mild symptoms. So whether it is a sepsis or whether it is something else. So in those scenarios, actually, you have a role of septic screen. Like in the previous case scenario, where actually baby is symptomatic and baby is having multiple risk factors, there is no role of septic screen, because anyhow, like even if it comes positive or negative, you will start antibiotic, isn't it? But in this scenario where actually you have mild symptoms, but you are not sure whether it is sepsis or something else, then in those situations you have role of septic screen. So now, what are the components of septic screen? Classically, like there are in the conventional septic screen, there are 5 parameters: TLC, ANC, CRP, IT ratio, and micro ESR. So total leukocyte count, like both leukopenia as well as leukocytosis, but leukopenia is more significant as compared to leukocytosis. So if TLC is less than 5,000, it is significant, and ANC, absolute neutrophil count, neutropenia less than 1,000 is significant. And for the cutoffs, actually you need to look into the charts. Like for term babies, we have Monroe's charts, and for preterm babies, we have Mozino's charts. So actually, it has got a wide range. The neutrophil count has got wide range in the first 72 hours and subsequently also. So the wide range will be there between like on day 2 as well as day 3. So once you get the absolute neutrophil count, you plot that in that nomogram and see whether it is really abnormal or normal. And CRP, one of the most widely used parameter across most of the neonatal units. So if it is more than 10, it is given significance. More. So here I would like to tell you one more thing. So it also depends on the unit also, of course. Actually, different labs will give in different way. Like in some units will give more than 1 as cutoff, and some labs will give more than 10 as cutoff. Some labs will give more than 6 as cutoffs. But you need to look into the units. So if it is milligram per liter, then more than 10 is significant, and if it is milligram per deciliter, more than 1 is significant. So IT ratio, immature to total ratio, if it is more than 0.2, which means that actually the immature cells are more than 20% of the total cells. So that again significant. Micro ESR is not widely used nowadays, but this is the cutoff, like a value more than 10 mm is significant. So like out of all these parameters, any 2 parameters are positive means it is positive septic screen. And one of the like among these 5 parameters, CRP is the most important, followed by IT ratio. So now what are the so now we discussed regarding the role of conventional septic screen. So in this particular case, actually, like in the previous case which we discussed, so as I was telling, actually the decision is already made. Like you need to start antibiotics because it is a symptomatic baby. So really there is no there's no significant role of septic screen in those situations. So in the second scenario, it will help us in decision making. So if it comes positive means the chance of having sepsis is more. If it comes negative means the chance of having sepsis is less. In those scenarios, like if the baby has mild symptoms, abdominal distension, pre-feed aspirates, and baby septic screen is negative. So in those scenarios, actually we can wait. We need not start antibiotic and expose the baby to antibiotics. So you can wait for and you can monitor the baby closely for the next 1 to 1.5 days. So now, what are the problems with septic screen, and is there any role of repeating the screen if the first septic screen comes negative? So the problems with septic screen are, it is like all the parameters which are there, they are basically the inflammatory parameters, isn't it? So sometimes it can be falsely positive and sometimes it can be falsely negative also. The false positive means like there is no sepsis, but the reports are coming positive. So what are the situations? So in other causes of inflammation, like a baby with birth asphyxia, a baby with meconium aspiration, okay, a baby post-surgical baby. So in many of these situations, the septic screen can be falsely positive. So what are the situations where it is falsely negative? So sometimes actually if you are doing quite early in the course of the sepsis, so it can be falsely negative, or in case of like early onset sepsis also in the first few hours it can be negative, and if you repeat after 12 hours, 24 hours, it may come positive. So now comes the next question. So is there any role of repeating the screen? So usually like if the first screen, if it is negative, so if clinical suspicion of sepsis is strong, then we repeat the septic screen after 12 to 24 hours to see whether the parameters will turn positive. So if it is positive, then you will take decision accordingly. So some of the important take-home messages regarding septic screen are: the septic screen is useful for ruling out sepsis rather than ruling in sepsis. So that means that actually like you are suspecting, and if the test comes negative, then actually you can rule out sepsis in most of the cases. And the second important thing is it has got good negative predictive value. So which means that again, if it comes negative, that means the chance of having sepsis is less. So this is applicable more for late onset sepsis as compared to early onset sepsis. And we should be aware of false negative as well as false positive situations, because it is a simple inflammatory marker. And if the baby is really sick and if the clinical suspicion of sepsis is strong, definitely it won't help in decision making. For example, I have a baby who is having who is having shock, or who is having core periphery temperature difference significantly, or scleroderma. So those kind of things actually definitely it won't help in decision making. Anyhow, you will start antibiotics. Now comes to the role of other newer markers. So a couple of words about these newer things also, because now actually like in most of the neonatal units, NICUs, and down the line even SNCUs also may start these markers, procalcitonin. So we should know what are the pros and cons, and we should also know what is the role of procalcitonin in early onset sepsis versus late onset sepsis. So the PCT, procalcitonin, normally like after birth, what happens is it rises naturally over the first 24 to 36 hours. And after that, it will come to a plateau. So in the first 48 hours, actually like it can be falsely abnormal also, like even without sepsis also, it may show positive value. So that is one thing. So that's why the diagnostic accuracy of PCT is better in case of late onset sepsis as compared to early onset sepsis. And just a comparison between CRP and PCT. CRP, like whenever the baby is having sepsis, there will be late rise as compared to PCT. So it will start rising after 12 hours to 24 hours, and it peaks by 48 hours. And it is not very sensitive or specific, as we discussed in the previous slides. But PCT, so the rise will be early, like after the endotoxin enters the blood from bacteria. So within 4 hours, it will start rising, and it will be peak by 8 to 10 hours. And it is more sensitive and specific, and it also correlates with the sepsis severity. So if the sepsis is more, then PCT values will be more, and it also is useful for the prognostication also, like any value beyond 10 is associated with poor prognosis. So these are some of the advantages of PCT as compared to your conventional screen and CRP. So role I told you, like in case of late onset sepsis, actually the role is better as compared to early onset sepsis. So now there are many other newer diagnostic markers are also coming. Like you need not know all those things, but there are markers like PCR which is coming up. There are many cytokines, actually cell surface antigens, which are coming up. So I think this is one of the important slide which you should know. So as you can see here, so on x-axis this is the timeline, and this is the time point of like endotoxin entry. So within like usually the baby will start having symptoms somewhere here, like at beyond 8 hours to 10 hours. So after the endotoxemia, like the baby will develop features of systemic inflammatory response syndrome, and after that baby will develop all the symptoms. By almost 20 so like this, and subsequently there will be plateau and it will come down. Whereas PCT, the rise will be much more early after endotoxemia. And you have other parameters like the cytokines and interleukin 6 and 8, actually they will start quite early. So this is the timeline for different sepsis parameters. Now coming to the another aspect. So till now we discussed risk stratification, and the second aspect is septic screen as well as other diagnostic markers. Now about blood cultures. So we discussed two case scenarios till now, isn't it? So is blood culture is needed in both the scenarios? In any situation where you are starting antibiotics, so always blood culture is needed. So in the first scenario, definitely blood culture is needed. In the second scenario, which I discussed, if the septic screen comes positive, then and you are contemplating to start antibiotics, then definitely you need to take blood culture. Well, maybe you have a doubt about sepsis, your septic screen negative, and you have taken decision of withholding antibiotics for next 24 hours, then you need not start, you need not take culture at that point of time. So now how to improve blood culture yield also. So this is another important aspect, because often like you send blood culture and you will keep on waiting for the culture report for the next 48 to 72 hours, and at the end of the day actually it will come negative. In neonates it is said that the culture yield is only up to 30 to 40%, but this is true with the conventional cultures. And actually that information is a very important information for us. Like we need blood cultures to like to take decision on antibiotics and to upgrade or downgrade the antibiotics, and also to take decision on the duration of antibiotics. This is very important, but many times it comes negative. So how to improve the culture yield? So these are some of the important steps which we need to follow to improve the culture yield. So we need to take aseptic precautions, good preparation of the skin, triple swab technique, or if you are using 2% chloroxidine, that is always good. And don't take from indwelling catheters. So if there is already umbilical line, don't take from that. And if you are taking the blood, actually take at least 1 ml. And usually the medium volume will be, culture media volume will be around 10 ml. So it should be in the ratio of 1:10 to get good growth. And now actually, as compared to conventional cultures, now most of the units they are using and most of the labs they are using backtech or backed alert cultures. So which will be like the yield is much more, and actually you will get the report also more early. And another important aspect, more practical thing, especially in SNCU, is like incubate at normal temperature while in NSU. Why I am telling is like sometimes actually the babies deteriorate during the night time, and you will take blood culture and you will keep in the refrigerator. So because in refrigerator the temperature is 4 degrees centigrade like that. So what happens is actually it will be bacteriostatic, or so that's why like once you send the culture in the next day morning, the yield will be less. So routinely other samples we keep in the refrigerator, but for culture we need to keep at the room temperature only. So this is another practical aspect. So now we discussed this particular question. And this is again important more for the doctors as compared to nurses. So whoever the residents and SNCU doctors. So how should we use this information? Like once you get blood culture, so how to formulate empirical antibiotic policy? So this is another important aspect which we should know. So based on your antibiotic sensitivity, based on the unit organisms as well as based on the antibiotic sensitivity, you devise your own policy. Like what is the first line, what is the second line, what is the third line, like that, isn't it? So for that, like what is needed is at least we need 1 year data, last 1 year data. For example, from tomorrow onwards, I need to make my unit antibiotic policy. So I need to look at last 1 year data, and at least 6 months data we need to see. And we should have at least 30 positive cultures to get any meaningful data. And based on that, we prepare an antibiogram. There's a like a chart kind of thing we'll prepare. And more important thing is this aspect, like for the first line antibiotics, it should be able to cover at least 70% of the unit organisms. For second line antibiotics, it should be able to cover 90% of the unit organisms. And for the third line, at least 95% of the unit organisms. So that is regarding antibiotic policy. Now coming to choosing the right antibiotic. So again, I'll start with a case scenario to take decision on starting antibiotic in NICU or SNCU and which antibiotic and how long. So now we have a one case scenario like term baby admitted as a baby didn't cry at birth. Baby jittery and lethargic, but there are no other risk factor for sepsis and diagnosed as probably HAE stage 1, like a baby had irritable cry subsequently in the first 24 hours. So probably HAE stage 1 is the clinical diagnosis. So that is one scenario. And you have another baby, 31 weeker, day 4. So baby came to you from some other hospital on day 4. And there was a preterm onset of labor. Baby initially required RDS, surfactant for RDS. And baby was also given CPAP. And on day 3 and day 4, baby developed apneic episodes, cool peripheries, and poor perfusion. And baby came to you on day 4, referred by some other hospital. So now, will you start antibiotic in both the situations? So answer is definitely no. Like in the first situation, we can definitely wait for starting antibiotics. So that baby doesn't need antibiotics, isn't it? In the second scenario, baby already preterm, already required multiple interventions, came to you on day 4 with clinical worsening, poor perfusion. So definitely we'll start antibiotic. So here at this point, I would like to stress upon particular aspect, like what are the situations where we can avoid antibiotics in SNCUs. So it is just a common practice that once the baby comes to SNCU from even from labor room also, inborn baby also, like just people start antibiotic Paxim or Pipjo, fibrocin tazobactam, like that people will start. So that is not correct. So we should be able to do antibiotic stewardship. We should be able to curtail use of antibiotics as much as possible. So these are the situations where we can avoid antibiotics. So a baby with asphyxia, like milder degrees of asphyxia, HI stage 1, no risk factors, you can avoid. Baby HI stage 2 and 3 requiring ventilation or therapeutic hypothermia, of course, those are not the scenarios. So mild delayed cry and mild asphyxia, baby, no HI or HI stage 1, you can always wait. And if a baby is admitted for monitoring, IDM baby on IV fluids and monitoring for hypoglycemia, we need not start. Well preterm baby admitted for low birth weight care, we need not start. Severe jaundice, so babies who is having a value of 18-20 bilirubin, so baby will be under phototherapy and also will be on IV fluids and also will be on antibiotics. So again, this practice should not be there. Meconium aspiration. So milder meconium aspiration requiring only oxygen without any positive pressure ventilation. So you need not start antibiotics. Babies admitted for surgery need not start antibiotics. So basically the bottom line is there is no role of prophylactic antibiotics, and these are all the situations where you can really avoid antibiotics and you can do antibiotic stewardship. So now coming to which antibiotic to start. So if it is occurring in the first 72 hours, early onset sepsis and late onset sepsis, or if it occurs in the hospital, like hospital healthcare associated infections. So what are the antibiotics which we need to use? So here I would like to suggest one more thing. Don't call hospital acquired infection or nosocomial infection. So now the terminology is changed. So it is healthcare associated infection, because in the hospital, healthcare professionals, we don't want to give infection, isn't it, to the babies? So it is not hospital acquired, it is healthcare associated infection. So to give the antibiotics actually, so these are some of the basic principles, like which antibiotic to choose. So I'll tell the basic principles for empirical antibiotic policy, and also like what antibiotics we use in our unit. So it may be different in different units. So basically, like we need to look at the blood cultures, at least last 1 year data or 6 months data. And we need to give broad spectrum cover, like gram negative and gram positive, depending on the clinical scenario. So routinely, if it is early onset sepsis, so gram negative cover is must. And if in doubt, cover for gram positive also. First line, choose from aminoglycosides, ampicillin or fluoroquinolin or piperacillin, and avoids cephalosporin as first line. So because it is associated with increased incidence of fungal sepsis in the unit. So if there is any coexisting features like pustules, abscess, pneumonia, so in those situations, give staph cover also. So these are some of the broad principles, and this is our unit antibiotic policy. So what we do for early onset and what we do for late onset sepsis. So if it is early onset sepsis, the first line will be like amikacin monotherapy if the baby is asymptomatic and you are starting antibiotic only for the maternal risk factors. And if a baby who is symptomatic, I'll start amikacin along with ampicillin. Second line will be piperacillin tazobactam with amikacin. Third line, miro with vanco or linezolid. Whereas in late onset sepsis, the first line will be piperacillin tazobactam and amikacin. Second line, miro and levofloxacin. Third line, miro plus vanco or linezolid plus fluconazole. And amphotericin, colistin, and tigecycline, these are some of the reserve drugs. So now coming to the LP, lumbar puncture. So we discussed regarding blood cultures. So now what about LP? So our blood culture I have already discussed. So whenever you are starting antibiotics, you need to send blood culture prior to starting antibiotics. So always like it's a good culture. So we have to develop a culture to send blood culture in our unit. So now coming to the lumbar puncture, LP. So it is mandatory for all the cases of late onset sepsis. And in case of symptomatic early onset sepsis also, it is required in most of the scenarios. In some of the scenarios we can avoid, like in a baby who is asymptomatic, with perinatal risk factors and you are starting antibiotics only because there are significant perinatal risk factors, or baby is having RDS and you have diagnosed the etiology as something like HMD. So in those situations you can avoid. And this is one flow chart actually which discusses regarding lumbar puncture. So the contraindications of lumbar puncture is like if the baby is having coagulopathy, if the baby is having increased features of any increased raised ICP, skin infections at that site, or baby is clinically unstable, like if baby intubated and having significant thrombocytopenia. So usually if the platelet count is beyond 30,000, you can always go ahead and do lumbar puncture. So thrombocytopenia is like a relative contraindication. So more than 30,000 is safe. Okay, so going on, actually, so what happened to this particular case? The second scenario which I have given, so baby shifted from, baby came to you from some other hospital. So on evaluation, this particular baby had high CRP, IT ratio is also positive, and initially you have started antibiotics, piperacillin, tazobactam with amikacin. So now, in that particular case, what happened is the baby had shown some worsening, like baby developed tachycardia, peripheries became cool, and there were altered aspirates in the next 12 hours. So what will be your action? So, and whether, and it's a actually knee-jerk response that actually people start changing the antibiotics. People will hike up the antibiotics. So you have started piperacillin and amikacin, now you go to the third line. Okay, you go to miro and vancomycin or colistin, something like that. So is it required or we can wait? So broadly, like as a general principle, you don't change the antibiotics before 48 hours unless baby is quite sick, like scleroderma or something else. So what is important is at that point of time, the treatment of sepsis is not only antibiotics, it is also good supportive care. You need to give good supportive care along with antibiotics and sometimes adjunctive therapies. So, like baby requires like proper maintenance of the temperature, and baby will require oxygen. Baby will require fluids, properly bolus. So all this supportive therapy is important. So don't just hike up the antibiotics. And you also should have a unit policy, like what are the situations where you can change from first line to second line and who can prescribe these things. Otherwise, in every 12 hours, like the antibiotics will keep on changed. So this particular baby at 48 hours, actually the blood culture is positive and grown Klebsiella, and it is sensitive to piperacillin, meropenem as well as ceftazidime. And with supportive care in this particular scenario, we didn't hike up the antibiotics, and piperacillin tazobactam along with supportive care was continued, and baby started showing improvement by 48 to 72 hours, and by that time we got the culture also. So retrospectively, our decision is correct that we didn't hike up the antibiotics. So now, what are the common organisms in your units? So in our unit, actually these are the common organisms, and this is true in most of the other units also, like Klebsiella, E. coli, Staph, Pseudomonas, cons. So these are the common organisms. Candida is a common organism in some of the units. So now, how long to give antibiotics? So for culture positive sepsis, first scenario, we need to give for 14 days. Whereas culture negative sepsis and probable sepsis, we need to give for 7 days. That means septic screen is positive. And in a sick baby with septic shock, usually we give up to 10 days. In pneumonia, again, 10 days. So now one word about fungal sepsis. So what are the risk factors for fungal sepsis and what are the antifungals of choice? So what are the risk factors? So there are like you don't suspect fungal sepsis in each and every baby. So one thing, you look at your unit flora, but the risk factors for fungal sepsis are like if you are having a ELBW baby or VLBW baby, less than 1.5 kilo baby, prolonged lines. So you have umbilical line more than 1 week to 2 weeks, and prolonged PICC lines. And baby is on total parenteral nutrition, baby required multiple transfusions, TPN. So these are all the risk factors for fungal sepsis. So you need not start antifungals in each and every baby with the suspected sepsis. So now what are the antifungals of choice? So this again depends upon the unit organisms and their sensitivity. Most of the units actually the fluconazole, like Candida albicans is the most common organism and it is commonly sensitive to fluconazole. So most of the units actually we can start fluconazole, but in terms of efficacy, so amphotericin is better. And second thing is if you are getting more of non-albicans group, Candida non-albicans group, then in those scenarios actually you need to start amphotericin. And if you are contemplating to start amphotericin, so liposomal amphotericin is always better as compared to amphotericin. This is because the side effects are less with liposomal amphotericin and you can give more dose. For conventional amphotericin, plain amphotericin, the dose is like 1 milligram per kg per day, whereas in liposomal you can go up to 4 to 5 mg per kg per day. So in a case of suspected fungal sepsis, you need to do urine evaluation, urine for fungal elements, as well as ultrasound kidneys to look for the fungal balls, as well as aphthal assessment to complete the evaluation. So now, what is the role of immunoglobulins as well as other adjunctive therapies? So some of the units they start immunoglobulins, IVIG. So according to the evidence and according to the literature, there is no significant benefit of starting immunoglobulins in case of sepsis. So if you at all you are giving actually in a sick baby and the baby is not improving with antibiotics or having septic shock or scleroderma, so in occasional case you can start as a adjunctive therapy on one-to-one case basis. So you can't formulate a general protocol like this is useful or this is not useful, but on case-to-case basis after discussing with the parents, you may occasionally start, because actually the evidence is not strong and evidence-wise it is not really that useful. So now coming to last aspect, last couple of aspects. So now what is about antibiotic stewardship? So what are the principles? So basically the word antibiotic stewardship means, so you don't want to use antibiotics unnecessarily, you want to curtail, you want to reduce the use of antibiotics as much as possible. This is this can be done by various ways. So these are all the important aspects of antibiotic stewardship. So one thing is educating the staff. So once you like regarding the like pros and cons of antibiotics and problems with excessive use of antibiotics. So if you are using excessively, so it again leads to fungal sepsis and again leads to many other problems like necrotizing enterocolitis. And having interdisciplinary approach, that means like backup of microbiology. So if you get if you have good backup of microbiology, then your actual use of antibiotics will be less, isn't it? Otherwise you will keep on giving multiple antibiotics. So pipjo will be going on, meropenem, colistin, fluconazole, everything will go on. So if you have good microbiology backup and you have a culture which is positive and say you know that actually it is sensitive to particular antibiotic, you can stop after some time. I mean you can downgrade your antibiotics and you can titrate your antibiotics. And so these are all the different aspects like educating the staff and interdisciplinary approach and good housekeeping practices. So prevention of infection and good labor room practices and having like improving the blood culture yield. So these are all the different aspects of antibiotic stewardship. So now coming to the, I think last couple of minutes. So many times we think it is only sepsis, but babies may not improve with your antibiotics and routine care. So after 2 to 3 days, you think it is something else, probably something else, and you are treating for sepsis and baby deteriorates. So what are such, those situations and what are the other differential diagnoses for sepsis? So here I would like to add one more thing also. Sepsis is one of the most common diagnosis in SNCU and it is also one of the most common misdiagnosis also. So like for many under the umbrella of sepsis, actually many inborn errors, many cardiac disorders, they will be missed, and actually by the time you think of those things, you will lose precious time. So let me give this particular case scenario. A 38-weeker, 3 kg baby, 15 days old, referred from outside hospital, and initial workup for sepsis is negative, and baby is having lethargy, jaundice, hepatosplenomegaly, fever, pallor, and poor perfusion. So what are the differential diagnoses here? It's not about bacterial sepsis, so there are many other things which can mimic like this. So for example, baby is having hepatosplenomegaly, pallor. So malaria, congenital malaria is possibility. Baby is having poor feeding, lethargy, jaundice. So again, inborn errors like especially metabolic disorders like galactosemia with sepsis. So these are some of the differential diagnoses which we need to keep. So you need to think of other sepsis mimics also, and you need to think of non-bacterial cause. So there can be other non-bacterial cause, like these days in the area of pandemic, you need to like you are having epidemic of dengue, you are having pandemic of COVID. So you need to think of those differential diagnoses also. So whether it's a neonatal dengue, whether it's a neonatal COVID. And you need to think of even routine metabolic causes like hypoglycemia, hypocalcemia, these things. And many viral sepsis like herpes also can present like this. So herpes sepsis. So some of the clues are like baby might be having the vesicles on the skin, eye, as well as mucosal membranes, but they may not be there also. So what I'm trying to say is, like, under the umbrella of sepsis, we may miss many other common differential diagnoses. These are also not so uncommon. You need to think of inborn errors, you need to think of routine metabolic causes, you need to think of non-bacterial causes of sepsis also. So these are some of the sepsis mimics, like which can mimic sepsis, inborn errors, endocrine causes, other causes like dengue, these things. So whenever you are having a baby who is not fitting with the usual course, and there are no risk factor for sepsis, and if there are atypical symptoms like any vesicles, those kind of thing, and if you are contemplating to give more than 2 sets of antibiotics, so these are the scenarios where you need to think of, strongly think of whether probably it is not routine sepsis. So one word about prevention. I think actually in last couple of lectures in this month, actually the entire focus is on prevention of sepsis, but I'd like to add one slide about prevention. So good labor room care, good birthing practices, resuscitation. So this is one of the common area, like most of the labor rooms are not clean, and most of the babies acquire sepsis from labor room itself. So good labor room care and good practice in the delivery room. So that is one of the very important aspect. And early enteral nutrition with expressed breast milk. So again, it will prevent sepsis. And good housekeeping practices and good bundle care. That means, like for example, if a baby is on ventilator, you need to use WAP bundle. So which we are going to discuss in the subsequent sessions. Again, if a baby is on central line, so you need to use CLAPSI bundle. So to prevent WAP as well as central line infections. So some of the take-home messages from my talk on sepsis is, so for septic screen, it is useful for ruling out sepsis, and you should be aware of false negative as well as false positive. And prevention is more important, like which we discussed just now, all these 4 practices. And always send blood culture before starting antibiotics, and you have to believe your blood cultures. And antibiotic decision is based on the unit flora as well as its sensitivity, and there is no role of any prophylactic antibiotics, and there are many situations where you can really avoid antibiotics. So this is duration of antibiotic: septic screen positive 7 days, culture positive 14 days, meningitis 21 days, and pneumonia 10 days. And it's not always about bacterial sepsis. You need to keep other things also in your mind, which is called sepsis mimics. So inborn errors, metabolic causes. So these are all the things which you need to think of. And antibiotic stewardship is very important, and try to reduce the use of antibiotics. And many times, actually, if you are in doubt, you may start antibiotic early, but don't hesitate to stop early. So we'll start, and once you start it, actually it will go on for 1 week, 10 days, 15 days, like that. So that should not be done. So if the baby is sick and you start antibiotic and subsequently baby course is not suggestive of sepsis and your parameters are negative, then don't hesitate to stop early. So that's the one of the best way to reduce the use of antibiotics. So thank you very much for patient hearing, and I'll be happy to take any queries. Thank you.
Thank you so much, sir, for the informative presentation.